The EXTEND trial is a randomized phase 2 basket trial assessing the role of metastasis-directed therapy, which is to say local therapy, for patients with what we call oligometastatic disease. Oligometastatic is defined in this trial as patients having 5 or fewer discrete sites, lesions of metastatic disease, and the question is whether or not by adding local therapy, primarily radiation therapy, to each of these spots, whether or not this might improve patient outcomes. So the EXTEND trial took patients with oligometastatic pancreas cancer, as presented here at ASCO GI, and randomized them either to standard of care systemic therapy or metastasis-directed local therapy, followed by more systemic therapy, and asking whether or not that by adding the local therapy, we might improve patients' progression-free survival. The trial found that after enrolling and randomizing 40 patients eligible for analysis, that the progression-free survival time was markedly improved with the addition of metastasis-directed therapy. The median progression-free survival time for patients on the control arm was 2.5 months, compared with 10.3 months on patients who were treated with metastasis-directed therapy, corresponding to a hazard ratio of 0.43 and a p-value of 0.03. Furthermore, the trial looked at exploratory translational correlatives, demonstrating that by adding metastasis-directed therapy, patients' systemic immune profiles showed marked increase in activity, and this might in turn correspond to increased immune activation from radiation that could improve systemic disease control. So many possible future directions based on this trial, but this is the first indication that by treating oligometastatic disease comprehensively with local therapy, patients might have improved outcomes. We don't know that one local therapy necessarily does better than another, but as this is the first and only randomized trial completed to date in this setting, we have results for what radiation might do in this space. Radiation therapy in this trial was associated with very modest toxicities. Only one grade 2 adverse event occurred related to receipt of MDT using radiation therapy. Notably, things like surgical resection, especially for primary tumors in pancreatic cancer with procedures like the Whipple procedure, are generally associated with markedly higher rates of morbidity and mortality, suggesting that radiation therapy may be an ideal local therapy for this, conferring durable local control without exceedingly high risk of side effects. It remains an active area investigation and the subject of future translational studies by our group and others. The thought might be that by doing high-dose ablative radiation, that you're exposing the systemic immune system to cancer neoantigens and allowing for infiltration and activation of CD8-positive T cells, among others. This might allow systemic immune surveillance of micrometastatic disease to be augmented, and this in turn could be one of the ways in which, by doing local therapy in this setting, patients have improved outcomes. In addition to publishing and reporting on the results that we've presented here and waiting for longer-term follow-up for outcomes like overall survival, we're looking towards next steps in terms of innovative combination therapies, and this might include combination strategies that capitalize on immune activation. And similarly, we know that for oligometastatic disease, confirmatory larger-scale phase 3 trials are generally indicated, and that's true of this setting as well. We need to know that these data are generalizable with a larger patient population, and so to that end, a phase 3 trial hopefully is on the horizon.